Brooks here? Okay, great. All right, if everyone will stay seated, we'll start our next session. We're not taking a break here. If everyone will sit down quietly. Please take your seats. Please take your seats so we can begin. Have the conversations outside. So thank you again. I said it's a lot. One of our roles is to keep the industry and our membership apprised of developments, and legal and otherwise. And so on our next panel, we're going to talk about the expansion pharmacy. You know, pharmacy is really a low-hanging fruit for many worksite centers to take advantage of it. Why have people have to leave the worksite to get drugs or get pharmacist counseling or have to pay out of pocket if in fact they can provide this at the center? So I'm pleased to have with us today Betsy Bigler, President and CEO of Northwind Pharmaceuticals, and Brooks Smith, Assistant Vice President of Provider Dispensing for Premise Health. And we're going to ask them a series of questions. And again, if you have questions relating to pharmacy, again, send a text to me at 847-606-5527. So first of all, Betsy and Brooks, why don't you describe your operations and who you serve right now?
Thanks for having us. I'm Betsy Bigler. I'm a nurse by background, and so a lot of what Brooks and I will be talking is really a clinical viewpoint. Northwind Pharmaceuticals today is a repackager, a wholesale distributor, a closed-door home delivery pharmacy, and offers pharmacy services administration or PBM replacements.
And I am Brooks Smith, and I've been with Premise for 14 years. We have a wide variety of ways we provide medications to our members and our patients, not the least of which is provider dispensing, which is kind of where I've lived for the last 14 years. And it's really changed a whole lot and grown. So this topic kind of appeals to me.
Great. So let's start at the very beginning. Why should an employer who's considering or has a worksite center offer pharmacy services?
I'll take it first,
Okay.
if that's okay. So I think if you go back to why you considered a health center or maybe in its infancy, a clinic in the first place, you really probably went through a series of quality, people health, financial implications. You said, look, I have a medical carrier, but I'm not willing to leave that to chance. And so I'm seeing that I have a medical plan, but people are not accessing it in the way that they need to. And I want to take control of that. And I want to give them the tools and resources they need to take care of themselves through a health center experience. And you saw that that was good and it was doing good. And over time, you added additional benefits. So your OC health, you have mental health, you have PT, you might have dentistry, and you've added all of these other things that you're like, I have that benefit in place, but people don't know about it. They aren't accessing it. And I want to bring that into the health center. And so pharmacy is much the same way. And it's a relatively untapped opportunity to put into your health center. But today, as employers, as partners, we think of pharmacy benefits as PBM only. And that's really just not true. And they agree with us, clearly.
Got to be more exciting than pharmacy.
Yeah, I think, hopefully we get that level of applause at the end of this. But when you really think about kind of taking your health center and the premise of having a benefit for your members, excluding pharmacy is really just leaving that to chance as well. And so you get year-end reports. You get, 12 months ago, this is what happened to someone in January, but it's April of the next year. And you're not sure if that person is on plan anymore. You don't know if they had a catastrophic event. Everything's hindsight 2020. You get a 59-page report at the end of the year with a bunch of tables and no direction. And they're all like, well, it's kind of good, but it wasn't great. And it's going to cost you more this year. So looking into your health center as an opportunity to integrate your pharmacy benefit. And by that, I mean, all ways that you and your members access pharmaceuticals or medical supplies is definitely a total opportunity to bring your health center into a very integrated experience and drive total outcomes for your members.
Also, one of the things that we have been blessed with in Worksite Health is that we can kind of act and care for our members in ways that don't occur out in retail or out in normal PBM or carrier type situations. We can get rid of some of those silos and truly communicate within the care of that patient. And when you can take down those hurdles or those barriers to healthcare, that's where I think the best care is provided. And so we don't have to look at sending our prescription to X pharmacy and hey, I'm going to come by and pick that up. No, you're going to pick it up 4 hours later, on your way home after work. With on-site, we're able to succinctly care for them and to integrate our care for those members.
Well, and without bringing prescription into your health center, you're really not giving your providers the tools and resources they need to take care of their patients. They're really set up in the same way in a traditional commercial world, which is I'm going to e-scribe this out to whatever pharmacy you tell me it needs to go to. And I have no clue how much that is. I have no clue what your copay is. I have no clue. Nobody's going to call me and tell me that you didn't pick it up. And you're just going to show up as a train wreck in another 3, 6, 9 months, and we're just going to repeat this cycle. And so while you can integrate pharmacy into your health center, your clinician is now empowered to say, okay, I know these meds are available to you. This is the plan design for that. I know what your copays are going to be, or your employers agreed to waive those copays. I can counsel you on the medications. We can monitor side effects. I can see you again in 2 weeks and check your blood pressure and make sure it's doing what it needs to do. And then we can make adjustments and tweaks. So this is about adding tools in your provider's toolbox, the way you think about integrating other services into that clinic.
And all that is really brought into when you stand back and look at healthcare in America, how siloed it is as far as the ability to communicate across the spectrum for patient care. And we're in a perfect setting for that. And that's why I've been here for as long as I have, because I think it is the right thing to do.
Yesterday, somebody mentioned people being afraid of accessing care because they were afraid of the diagnosis and what that was going to cost them. So they knew they were diabetic. They knew they didn't feel well. They knew they had high blood pressure issues. They knew they had migraines. But if somebody was actually going to tell them that, they were going to have to deal with that. They were going to have to go through. That's not, diabetes is not one prescriptions. It's test strips, Lancets, injectables, continuous glucose monitor. It's 10 to 15 prescriptions if you're diabetic kind of on day one. And that's a lot for our workforce that's struggling with all the things that we've also talked about, which is inflation or kids or remote work or remote school or all of those other challenges. And so this is one more challenge that you can really think about integrating into your health center to remove those barriers for them and make them not afraid of that diagnosis and say, I've got your back. This might be an overwhelming conversation to have and an overwhelming diagnosis, but I, as the employer, and you as the clinic provider, and you as the member or patient, I'm really going to wrap my arms around you and make sure this is a successful journey for you. We've got your back.
I don't want to get on a soapbox, but I do feel like because of a lot of the high deductible health plans that we're seeing down the road, there's going to be a lot of pent up medical claims that have not come forward, to Betsy's point. And so we're positioned well, I think, to be able to care holistically for those patients. And hopefully there'll be some opportunities for some of those barriers that are created by high deductible health plans to come down so that we don't see those big bumps in costs that I feel are coming our way.
So what would be the profile of an employer who should have a prescription drug service of one type or another? What would generate, how would someone determine whether it makes sense for them, whether they have savings, whether they have service, whether people need them? And what % of your population actually offer the different services?
Well, I think all is the first answer. So who should explore adding pharmacy services to their health center strategy? all of them. There are definitely different states or provider restrictions from a regulatory standpoint that may inhibit that being kind of a traditional on-site dispensary, which is really kind of step one and maybe a 5-step process that you can go through. But there's definitely, there are ways to work within the regulations in different states. The vast majority do allow on-site dispensing as a starting point. Many of you in the room already have that starting point and are thinking about, okay, how do I take this to the next level, really? But everybody needs a strategy. They need a men's health strategy, a women's health strategy, a thyroid strategy, a cardiovascular strategy. And the PBM is not necessarily the strategy. It's not your only strategy. It's one of the tools in your toolbox.
Yeah, I totally agree. I think that the PBM being so separate from the holistic care that you need and you want for members is, it's kind of sad that that's the way healthcare rose in this country. I agree with Betsy. Everybody needs to be able to fill that white space, because honestly, unless you are, getting a lot of health coaching or mental health coaching or whatever, the best way to make an impact for a provider is to be able to treat them, with medication. So if that script goes out to Betsy's pharmacy or Glenn's pharmacy, then that provider doesn't know if it's filled or not. 80% of the prescriptions, only 80% of the prescriptions are ever filled. And then when you look at the abandonment rate after that, we go through a lot of trouble and a lot of work and a lot of care, and then drop the ball at the end if we're not able to supply medication.
What are the different types of options an employer would have, depending on their budget and size and things, to offer prescription drug services?
And we have grown, man. When I came to on-site health in 2009, it was pretty cut and dry, but man, it has really changed so much since then. Even employers down to the 90 employee level, we can still do some things. Might not be provider dispensing, and definitely would not be a true count, pour, lick, and stick full pharmacy. But there are options there, and then it goes up from there. Obviously, provider dispensing, full on-site pharmacy, integrated care where you can bring in some of those specialty medications and brands, and really get some things that move the dial. It's exciting times.
I think to add to that, there is certainly a range of opportunities to get pharmaceuticals and other types of DME supplies closer to the point of care. So you can start with provider dispensing. If you have restrictions, there are definitely other networks to tap into. There's direct contracting opportunities. If you have been living in the generic only space, you probably are impacting. Maybe with the most robust on-site dispensary, maybe 3 to 4%, most likely probably less than 1% of your overall health spend, which means you're also impacting less than 1% of your members' spend too. So it's not high influence. You've got 25 to 30% of your total healthcare spend is tied up in pharmacy. And if that's untapped influence you can put into your clinic, that's an opportunity. Home delivery services, we all expect as consumers, the Amazon experience, we want something to show up in 2 days, and we want the 3, text messages like, I'm a block away, I'm coming. We want that. We want things showing up in our house, and we want it easy. So we don't want to have to remember to request a refill. We just kind of want it to show up. I mean, that's literally subscribe and save on Amazon. Like your toilet paper just shows up every month, so you don't have to remember it. So we want those types of home delivery experiences. It's also a way for you to expand without necessarily getting into on-site dispensaries that kind of turn into mini pharmacies over time. So it's a way for you to do some inventory control. There's certainly the opportunity to integrate full pharmacy services administration or get your PBM on board with your health center strategy. Somebody mentioned yesterday if they had a partner that was not on board or wasn't willing to do data share or wasn't willing to collaborate, that they would no longer be a partner. And we really haven't challenged our PBM partners to be supportive of our health center. And most often you'll see some of the, like, this is my zone, what you can and can't do in your health center versus you finding partners and you say, this is my health center strategy. This is where I want to be in 1, 2, 3 years. And you kind of need to get on board with that plan. Imagine if your health center provider knew exactly what was on plan, what required a prior auth, what required a step therapy, that they were actually proactively managing that formulary for your member. The experience for your member would be much more positive, certainly. And that's just access. That's about getting access to the medications they need. But it's really about how do you help that member get better? Medications are tools in their toolbox. And right now, they're often looked at as an expense. Like, well, if I add medication to the health center, that's going to cause more expense. No, you're shifting access. You're shifting the expense from kind of an obtuse area into a place that you can actually have visibility control over.
And in fact, you're kind of shifting that into an arena where colleagues can coordinate their care instead of it going out to pharmacy X that, really doesn't have a vested interest in what medication is chosen, what therapeutic category. Honestly, quite often the outcome, I hate to say that I'm a pharmacist, so I hate to say that, but the vested interest of a colleagues working together in worksite health creates some efficiencies from a cost perspective as well. To her point, yes, we don't live in that all generic world anymore. That has come and gone, but there are still, heavy percentage of patients that are treated therapeutically, effectively, safely with gold standard generics that, when you look at cost per day of therapy, man, that is a no-brainer. And so being able to coordinate the care between providers, between clinical pharmacists, between prepackers, between, all those different genres to provide the best things for the patient is an advantage that, doesn't exist in other healthcare channels.
How are you expanding the formularies that are available? Are you getting into more brands? Are you getting into biologics, specialty drugs, infusion? What do you see happening, and what are employers asking for?
Well, employers are asking for help. They're asking for solutions and strategies, especially I think yesterday we talked a lot about coming out of COVID and how do we get back to a better place, or how do we help our members dig out of the last couple of years as well. So they're asking for strategies. They're also looking for cost savings. We kind of all tread water for the last couple of years as employers and as health centers. And so we need to go back into seeing patients and how are we going to re-engage those? How are we going to get our remote workforce engaged? So sorry, the Spartans aren't cheering for me yet.
Well, they will.
So part of that is really looking clearly at your data and what's going on in both in your health center and your health plan, your claims, and your pharmacy data. And so some of that is getting to what are the problems and what's the low-hanging fruit. A lot of times on your PBM reports, you just get you get the stack of tables, but you really should be asking, what are the gaps? Who's not accessing this? What happens when the copay is over $10? How many claims are you seeing reverse after that? Those are things that you need to look for. What are your top therapeutic classes on medications? A lot of times we focus on like specialty is really expensive, but it might be 4 people on your plan, but you might have 600 diabetics on your plan and, 200 asthmatics and, 30 people who have migraines and have FMLA absenteeism issues. And so for us, it's about getting clear data and helping say, look, your health center is perfectly positioned to handle these few therapeutic classes. We have programs. Our provider is very engaged. You have a health coach on site. You have an RD. Why don't we have 90% of your diabetics engaged? Like, why do we only have 20%? So I think when you go to think about expanding formulary, it's not just saying, all right, well, they can have everything through the clinic. It's about being very intentional about how you're going to approach that and make it meaningful for both the member and the provider. You do need to have your provider on board. You also don't want to go down the route and say, well, now you can, prescribe X, Y, and Z. And they're like, I'm not comfortable with that, or that's not my niche either. So there's definitely some provider engagement, some consultant engagement. Your advisor probably needs to be involved in that conversation as well. And you need to really sit down, look at the data, and have a strategy.
I think that provider point is key because they are providing that care and they are seeing that patient. And so it wouldn't matter if Betsy and I brought in strychnine tablets. It really doesn't matter if the providers are not going to buy into it. But what we do need to do is educate ourselves in that there are more options nowadays within on-site health that go beyond acute and episodic antibiotics and a fluticasone like it used to be way back in the day. Obviously, there's probably some limits as far as provider dispensing to the meds that you can bring in. Some of these new specialty meds and high-cost brands, I would hate to think that was setting in my health center sometimes, but there are ways to circumvent that to where we can still get it to the patient and have that provider speak to that patient at the time that it's dispensed. And so that still is an access and a communication point. Again, I know I keep beating the same horse that does not exist out in normal healthcare channels.
Could you talk about how you measure the outcomes and savings as well as adherence? Do worksite centers or pharmacies offer better adherence, better compliance than not?
So pharmacy ROI is, it's not just acquisition, apples to apples. There's clinical savings and more cost-effective substitutions. There's pushing your generic utilization to 90%. So you've got that kind of, is it more cost-effective to do through your health center and direct contract for that and carve that out of the PBM or replace your PBM? But it's really actually about the total cost of care of the patient. And so is that patient who's engaging in the health center and they're receiving the meds, tools, and supplies that they need to take care of themselves, including brand generic or specialty, whatever you and your partners have discerned to be the appropriate formulary for that, is really about, did that decrease urgent care visits? Did it decrease ED visits? Did their wound on their foot heal? Did you avoid an amputation? Was that member using, see, they're on board with this. Were they $120,000 on your plan last year, and this year they're now $40,000 because they've engaged in the health center? So it's about using that to point at the total cost of care of that patient, and not just quantitatively in an ROI, but is that member able to show up and perform better? Do they have less absenteeism? Did they stick around at a time where you're trying really hard to keep your workforce and it's hard to find new members? If you offer really robust pharmacy through your health center, I think you'll see more stickiness and retention with your members, which is significant. I know in the union space, the pharmacy is used as an major benefit, and it is known day one that you join the union that you have a health center, and here are all the programs and the medications offered at no cost to you, and they are enrolled quickly and engaged quickly, and they stay engaged.
Great, thank
To
you.
that point, I can remember going to employee presentations at, like, say, a self-insured industrial client. And when they come in between shifts and you give out the formulary, and you've already talked about the app that they can use to make an appointment, and you give them a patient version, a simplified version of the formulary, and you see them physically look down through there and say, hey, that's my med. I'm going to get out my phone here and I'm going to book an appointment. And because I know this is free care, it doesn't have any hurdles to it, not a lot of copays, not a lot of costs. It's a huge carrot to drive utilization within our health centers. But better than that, once they get in the door, we have access to the Epics and the other EMRs of the world that can close gaps and can see things that even happen out in retail space that a normal provider that's not associated with that on-site health center would not be able to see. And so it's a good thing.
I also think oftentimes you start walking down the pharmacy path in your health center because you think the torvastatin is $4.95 and you can get it for $3.35. And so, and that is good. And the dollar is good. But really, when it comes to ROI, when you think about ROI through your pharmacy, the metrics on that dashboard should be engagement. How often did they come back after that? What type of comorbidities were discovered? How many screenings were done as a part of that engagement? Very programmatic approach. So I often put pharmacy dashboards together on ROI or programs that we do. And like the pharmacy piece is like in the upper right-hand corner, and everything else is about the patient's quality of care, their HEDIS measures, their outcomes, their engagement, their demographics, who engaged, who disengaged, and what are their A1Cs doing, what before and after. Hey, we had a school bus driver who couldn't pass her DOT exam, but after she joined the diabetes program, she could still drive the school bus in the fall. Like that really matters to school systems, to towns, to municipalities, to unions, to people who are trying to keep their workforce healthy enough to continue to contribute to the organization. So from an ROI perspective, there's a dollar amount there, but the dollars are actually over on the total cost of care.
Agreed. When you look at the total cost of care and treating that patient or treating even a group of patients, we want to take that hockey stick and change it as far as their trend cost. And so often we get caught up in the weeds of looking at minutia data when really a lot can be seen just from standing back and seeing the big picture of, have we impacted the cost of care? Have we impacted the outcomes? And are people's lives better because of what we're doing? And to me, there's some ROI in that. Yes, hugely down the road as far as cost avoidance. And I know that's soft dollars, but it's real. When you have that A1C under control, a patient at a time, and then you have a cohort A1C under control or trending down, then common sense tells you without a ton of studies that, hey, over time, we're avoiding a bunch of ER visits and a bunch of train wrecks.
Are medications free under HSA plans?
There are certain medications that can be offered at no out-of-pocket cost to the member. So there are specifically therapeutic classes that are or are not. Diabetes is actually one that you are allowed to sponsor at 100% for members. And there are some other cholesterol and blood pressure medications. That's also subject to interpretation.
Yeah, there's still some gray area in that.
I mean, I've had some employers who say anything that prevents chronic disease like insulin, I can offer for free because it's preventing people from getting worse. Is that an employer interpretation? Is that one the health center manager helps, or do you not recommend it?
The health center manager and probably more importantly, their pharmacy partner can help navigate some of that. The consultant also has some interpretations of that from their particular view. There are some clear guidances, and actually insulin is one that you can offer at no out-of-pocket cost, but the shades of gray start after that. You have a therapeutic class, and then they've specifically listed like 2 or 3 meds, but it's not comprehensive.
Right, absolutely. And at my advice, which doesn't mean a whole lot, but each employer needs to decide within their legal, their will, right to the world, what they want to see as far as are we going to be conservative in this approach? Because it is not delineated in black and white. There is a lot of movement within that space that, quite frankly, fits the words of the law.
Right.
And for someone who wants to interpret that very conservatively, you certainly can integrate, even through your health center, copay acceptance of medications that maybe don't qualify. So there are still options. Don't take that as an absolute stop if you are an HSA. And a lot of companies are HSA only, even at this point. And there's still ways to adjudicate even in a carve out mode or a carve in mode, copays and deduct those from different areas or have patients submit those. And that does require the next level of project management of actually getting all of your partners to your table, your TPAs and your PBMs all playing nice in the sandbox. So that's that's a challenge, but
Yeah.
it's a worthy challenge to have for the benefit of your member. And certainly ways to drive utilization of your clinic is to really think about your plan design, HSA or not, and make the health center and the prescription access through the health center a preferred way to do that, and augment your copays accordingly to create incentives for them to engage. If you're an HSA plan or a PPO plan, those types of strategies still apply. You can make your copay for generics no out-of-pocket cost with brands through a health center. It could be $10 versus a $50 or $70 copay they may experience out at retail.
Yeah, we can still incentivize utilization of the healthcare centers that are on site and still be in compliance. But Betsy made a great point. It's really about getting all the stakeholders involved, the TPAs, all those people who have an impact in the way that plan is ultimately administered and designed to benefit you, the employer.
What are some novel ways to integrate pharmacy into primary care of the center?
I'll tell you some that's not being tapped into enough. Betsy and I talked about this yesterday. One is vaccines. We do a fairly poor job of mining the data that comes in for our employers through their medical plan for medications. She and I, we live in PBM data world, and we can go down through there and we can glean out the percentage of medications that are diabetics and sulfonylureas and metformins and all that. But what we as an industry have a hard time doing is tapping into those medications that are administered on the health plan and not through the PBM. So that to me, that's the new ground that we need to plow in the medication piece of on-site health.
I think there needs to be a fundamental shift to defining your pharmacy benefit as the way that you want your members to access, not what your PBM tells you your plan is. And right now we as employers or partners are often kind of beholden to the PBM instead of thinking, this is my plan and I'm going to do vaccines in this strategy, and I'm going to offer over-the-counters here, and I'm going to have a health center strategy, and I'm going to have an international strategy, and I'm going to have a generic, and I'm going to have a program, and those kinds of things. So there's a fundamental shift in the way that we need to think about that as payers, essentially, as of a self-funded employer. And kind of taking control of that. I think that's the first novelty that needs to happen so that we can then expand our influence. I think the second thing, when you think about expanding formularies or adding additional services, is to really do that with a lot of intentionality and a lot of programmatic management. You will not, a self-funded employer who's agreeing to add diabetes medications to a formulary, and they are thousands of dollars, some monthly or every 3 months or so for a member and for the health plan. What they're saying by allowing you to have those on formulary is they want you to be accountable to that investment now. And so you're going to need to put structures and programs in place. You also want to hold the member accountable. So you want a little skin in the game from them. So from our standpoint, that's very programmatic engagement of medication tracking, cohort management, and creating the outcomes dashboards. An employer is going to come back to you and say, okay, I agreed to add these brand medications or specialty medications to the formulary. What happened? Was that good? And so you need to be prepared to be able to produce that level of detail for them to say, it was good. It saved you X, Y, and Z % against your PBM, but here's the 20 other things that happened. You had a member who avoided a foot amputation. You've got your retinal eye exams are all done, or this infusion would have been $30,000 and it was $15,000. You've got to be prepared for those kinds of reporting and the rigor around that, because by moving those things and shifting them out of a traditional retail network, you are now the person that they're going to hold responsible for the stewardship of that investment.
What kind of performance guarantees are employers asking you to put into your agreements? And what perhaps should they be asking that you could collect or report that they're not asking?
The standard one we're going to see most often is what is our percent generic, which is, pretty easy to come by in on-site health. But more and more, we're starting to see just what you talked about. What is my overall A1C of this population? What is the total triglycerides of my employees and their dependents? And have we made an impact in that within the health center? And we should be able to answer those questions. We, as clients, as employers, you care about your employees and their dependents, and we should all be held accountable. And we've got a great opportunity because we can work side by side with each other on any given day to impact those members.
And I think even as a pharmaceutical partner to the health center, we're being asked to step up to the plate as well and be a part of the total outcome of care. So, hey, Northwind, if we do X, Y, and Z, where are you willing to commit pharmacist time, consultative time, Betsy time, data analytics time, dashboards time, those kinds of things. From a performance guarantee, I think about that more in a service and outcomes. And we're definitely a partner in that and have a lot of influence over those outcomes. So for us, it's about actually being a part of that front end conversation with the self-funded employer on, hey, what's your strategy for X, Y, and Z employer? And how can I come to the table and help you be successful in that and meet your, what are your challenges or what have you put on the line at risk? What's your PG? Okay, well, here's some strategies that I think that we can deploy to help you meet your commitment and help the members get the outcomes that they want. So we're certainly an extension of that as a partner.
I mean, I have seen a change from asking, what percent of my people are on generics versus brand is what percent of my people on statins are adherent.
Right.
And so, the more drill down you can get, the better it would be.
And I think eventually we'll get to the point where it'll take a while, but we should arc over the bell curve eventually and start being able to, if we're doing the right things, we should be able to decrease the number of meds that a given member is on. And that's our ultimate goal. Yes, am I a pharmacist? Do I deal in medications? But the ultimate goal is we want to get those members healthy and off of medications. So that's kind of the big picture that I think will come down the road from employers. Maybe not soon, but at some point.
Yeah. Questions from the audience that haven't texted in yet? All right, so let's talk a little more about the PBM relationship. So if I don't have a center yet, I want to open one and I want to offer dispensing. Is that going to impact my PBM's performance guarantees? What are they going to feel that because I have a center now, they're going to charge the center a cost for them not filling the drug, or whose role, how does that role change then?
A lot of that is determined by, if you are self-insured, you make those decisions. I mean, that is your information. Those are your decisions to make. And one of the things that both Betsy and me and others in this space struggle with is getting data, because employers, for some reason, have never gotten the message often that, hey, that's my data. It doesn't have to come to me in a canned report that doesn't have quantity or days supply or any of those little tricks. I can get line by line data of what is dispensed, because it's mine and it's not Caremark's, it's not, Express Scripts. It's your data.
We have a saying, which is to ask for permission is to seek denial. And so this is about kind of arming yourself with your healthcare strategy and moving forward with what the right thing to do for you and your members and patients are. If your PBM gets twisted about the fact that you want a health center strategy, you might want to consider whether or not that's the right long-term partner for you. They should see that as a way for them to also positively influence the members. That should be your PBM's goal. And if it's not, there are PBMs out there who do have that goal and that shared vision for you. So I think you'll see pretty quickly whether or not that's a play nice in the sandbox situation, or whether that's a point where you need to consider other partners for sure.
That's a good point. Historically, it's been a struggle, and it really shouldn't be.
So when you talk about other partners, what if an employer wants to offer minimal prepackaged, but wants a contract, say, with a local pharmacy that may be across the street or nearby? Do you get involved in that? Does the center pay manager get involved? Do you negotiate a separate deal with that outside pharmacy? How do you approach that?
There can be some local contracting done. We have a couple of clients that have done that. And we still have some clients that even within that realm, at least historically, have still wanted to dispense something as well.
Mm-hmm. And so for someone who's either just starting or already has pharmacy services, what lessons or recommendations do you have to get more value from their investment?
I think 3 things. The first is get your arms around your data, get access to your data, your claims level data, good data, and either work with your PBM or a trusted partner who can help you analyze the efficacy of the pharmacy benefit that you're offering, and define pharmacy benefit as pharmacy benefit only or health center or other ways that you've allowed access to medications or supplies, and really start looking for the gaps. Everybody's going to want to reprice that, and that's fine, but everybody, including your own incumbent PBM, will come back with miraculous savings that they should have probably already been getting for you. So you probably want to talk to a third-party partner, your health center manager, or your pharmacy partners through your health center are great places to start. Consultants are also great places to start, and you're really starting to look for what's going on with my membership, not necessarily the dollars and cents, which is important, but who's getting what they need, what's my 30 to 90 count ratio, what is my generic utilization, how many patients are on specialty, how many diabetics do I have, how many asthmatics do I have? Oh, I have an substance abuse. I didn't even know I had patients on substance abuse medications. Do I need a strategy for that? So really get your arms around the data and start thinking about your next 1 to 3 year plan. Secondly, pick 1 to maybe 3 things to think about. But the first thing that you pick, execute the heck out of it, because you're going to come up with a strategy. You're going to market that to your membership. You're going to integrate it with your health center. And you want that first thing to be successful so that your members understand that you can make that frictionless, I think was the word yesterday. So you want to make it easy for them. You want it to be successful. It's going to take a lot of work. There's nothing that you can do in your health center that is not going to require engagement on behalf of the employer, the health center, the provider, your pharmacy partner, and everybody in between. And so start with one thing, maybe thinking about your second or third thing as well, and do it really, really well, would be my advice, and make sure you have the right people helping you be successful. And the third thing is just to remember that you are in command and control of your investment, both on your medical side and your pharmacy side. And so feel empowered to tell your partners how you want that to be envisioned, and find the right partners to help you execute on that.
If I had an advice of just one metric to keep up with within your care of your employees and their dependents, it would probably be cost per day of therapy. If I'm dealing with PBM X or whoever, that is important. That is something that is not brought to the forefront by PBMs or by a lot of people at the table, but we want to be able to be efficient with your dollars and good stewards with client dollars, and make sure that not only are we improving healthcare, but we're doing it from a good stewardship standpoint.
Great. Let's thank Betsy and Brooks for a nice presentation.